hydrocele is when there's unilateral or bilateral bulging of the scrotum. It's usually common in young kids between the age of 1 and 2. We usually refer to it as a fluid hernia or a communicating hydrocele. So basically what it means is around the testis there's a layer called the tunica vaginalis, which normally produces fluid around the testis. So with that, if there's a mismatch between absorption and production of that fluid, then you get accumulation of that fluid. What you're gonna have one side or both sides of the scrotum bulging, being full of fluid. It doesn't affect the testis. The testis is usually normal. It's just the accumulation of fluid around the testis. So you get two types, the communicating and the non-communicating. When we say communicating, that means it communicates with the abdomen. There's an area between the abdomen around the inguinal area, which is supposed to close when you are young, between 1 and 2. If it doesn't close, we call it the patent processus vaginalis. So fluid from the abdomen can just move freely to the scrotum, and then it accumulates, then present as a bulge. In adults, it's basically most of the time we don't know how it happens, but it's a mismatch between, as I've mentioned, the reabsorption and the production. In some patients, it's from the filariasis, which is a worm. And then in some cases, it's when there's inflammation in the testis or when there's a torsion of the testis as well. So basically, in most cases, you would present with a bulge and then we'll quickly examine. In children, basically that swelling is reducible if it's communicating, because when you compress on that fluid, it goes back to the abdomen, then it becomes a normal size. And at home, what you would see is that sometimes at night that bulge goes away. During the day, the child will be having a bulge in the inguina. So a fluid hernia in children is almost similar to an inguinal hernia, where part of the organs in the abdomen are herniating to the scrotum. So if it's fluid only, we call it a fluid hernia. So to make a diagnosis, it's clinical. If we can't reduce it and it doesn't change in size, that means it's a hydrocele, which is mainly we'll approach it when we operate it through the scrotal area. In kids, it's always advisable to be sure. If you're not sure, you can approach it through the inguinal canal. When we open the inguinal canal, we need to close the processus vaginalis so that there's no communication anymore, and then we drain the fluid. In some cases, we usually don't like aspirating the hydrocele. The main reason is that you can introduce infection, and then when you have that infection, it becomes a disaster to manage that case. If you end up developing an abscess, we call it a pyocele, it's all still a disaster. We have to open that wound and you have to stay with an open wound. So mostly what we do is either we can excise part of that tunica vaginalis and evert it, or we do a placation of that tunica vaginalis, and then that will reduce the recurrence. And in some cases, we use a sclerosing agent. So basically, we cause inflammation in that tunica vaginalis so that it doesn't produce more fluid anymore. And in most of the time, the main indication of operating is usually because of cosmesis. As I've mentioned before, the testis is normally fine. It's not associated with any pathology. It's just the problem of fluid which is accumulating. In some instances, if a child has that and then all of a sudden they get pain, we always go to our differential diagnosis, which if in the most important one will be testicular torsion, where testis turns and it closes its blood supply. We only have 6 hours. So in most instances, we'll do an ultrasound to confirm that the testis is not affected. If it's not affected, we're happy to manage it conservatively, and electively we can do an operation to sort it out.